You're listening to Ride Along, EMT School. I'm Mike.
And I'm Max. We're two students navigating EMT school, bringing you along week by week.
And I'm Jonathan, a paramedic bringing real-world perspective.
Join us as we share the lessons, challenges, and stories from EMT school, and hear insights from those already living the EMS life. Welcome to the Ride Along. I guess this is the part where we put in wise words from those already living the EMS life.
Lots of caffeine and don't kill anybody.
It's pretty wise.
I mean, that's kind of what I've gotten from all the experienced EMTs that I've met so far.
Yeah, I'm pretty sure that's the only thing Jonathan's ever taught me is
Exactly.
Caffeine and don't kill anybody.
Right.
Less caffeine, stop dipping sins, and exercise, get better sleep, and eat better.
Wow. Is that what you do after you're no longer an EMT?
Yeah, well, it could be the case that you're no longer doing the job anymore. And I don't say that as somebody that's the pot calling the kettle black in this instance, right? Like I'm trying to do those things, but that stuff's important. And as a culture and as a profession, we need to do better about all of that.
Indeed.
I agree. I mean, the thing that you bring in for lunch on your shift should not be primarily consisting of a sleeve of Zins. You know, like where they're shrink wrapped together, and you got them in bulk from the convenience store,
And that's going to last you all of an 8-hour shift.
Yeah,
Hey, it's like $11 for 5. Like, what do you want?
Hey.
Oh,
It's a deal.
Well, welcome everybody to
Indeed.
the Ride Along EMT School podcast. We're back again. We've got another episode for you.
And unlike last week, we're all here.
Yeah,
Indeed.
we are not flying the missing man formation this time.
I am back. Yeah. Just schedule wise, timing wise, didn't work out last week. So, but I'm back.
You know
I'm
what's
here.
You know what's funny though? When we first started this podcast, when I was like, "Hey, let me propose this idea to you, Jonathan." Me and Max are going through this school thing, and we're like, "You should join us." It was totally with this kind of like, whenever you're free, once in a while, join us and be this. And then we totally suckered him into being like the constant, consistent co-host that he is.
Yes.
Because we would have been lost
Through guilt, stress, crying a little bit.
So how many emails do we have requesting my presence in Pennsylvania?
At least
200, I think.
Yeah,
I think we passed 130, maybe 135.
I'm going to need to see receipts on this.
Yeah. How many different accounts does
I can make 4 probably by the end of the night.
I could definitely do 4. Easily.
So then
That's
we'll
8.
probably be at 8 total emails.
I think we actually have. I think we physically, legitimately have. I think 5 or 6.
Okay.
It's single digits. So if
Yeah.
anybody's out there listening and wants to send an email to ridealongpodcasting@gmail.com just to tell us how much you think Jonathan should move to Pennsylvania, please do.
Because by the way, that means that he's here live, right here.
Yeah, he'll be in the center.
Not through the screen, which means he won't. Instant reception, instant responses with the 3 of us. I mean, come on, people, get on it.
I mean, so here's a sneak peek, but I am looking at a contract potentially in Pennsylvania for the summer. So we'll see.
Potentially.
Potentially, yes.
So how do we just use leg irons for after the summer's over, or
I don't know. We'll figure something out. We've got all this time to figure out how we nail him to the ground here in the great Keystone State. But yeah, so we have Jonathan back. Last week we talked about more trauma without Jonathan. We did spinal.
Yes.
You missed the entire debate on backboarding and the controversy and it was really fun having 2 guys that are brand new into EMS talking about how EMS has changed
It's great.
It does not lend a ton of weight, but it's pretty well known that we've moved away from that type of stuff. But this week, what do we have? We have more trauma.
Yeah, but now we're talking about the chest and the abdomen. I mean, there's nothing important there, but I mean, it's if you have something that's just impaled you straight through your body, I mean, you'd be fine. You just wrap it with a rag, go to the emergency room, say, "Hey, this thing happened," right?
Yeah, I think that was week 4.
Yeah.
They taught us that.
Yeah.
It's been so long ago now.
It has been a while. So there's a lot of stuff going on in the chest and the abdomen. We're going to talk about it and the things that can happen and what's likely to happen when things happen.
Exactly. Yeah, we're it's like there's a lot in there.
A lot.
Like most of these, like I thought that trauma would be like a lot of like, oh, we're gonna talk about like the blood and the guts. Well, actually, this episode is blood and guts. But it's going to be like, oh, just action, and we get to talk about doing. And then of course, what we wind up having to do is kind of set the tone and kind of bring everything back around to the science, anatomy, and physiology, so that we understand what's happening when traumas are going on. So
well, not just that, but like you think you have all these sexy things that you could do to help, and the reality is, no.
Well,
no.
Some things you can, some things you can't. But
try and keep the red stuff in, and kind of try and keep the O2 going, and get him to the hospital.
Yeah, for and keep them stable. Yeah. Like the trauma seems to be much more about like, hey, don't make them worse.
Yes.
Like. Get them somewhere fast, as fast as you can with due regard, and don't make them any worse on the way. That would be great.
Yeah.
But this week we're talking about chest and abdominal trauma.
Yep.
And we have a sponsor.
We do.
It's one of our favorite sponsors.
It's my favorite.
They're all our favorite sponsors. We have a great relationship with a lot of companies now, which is so humbling.
Yes.
But this is one that has set a name in trauma, and we've talked about them a couple weeks ago. This episode is sponsored by Sam Medical. So penetrating chest trauma is one of those calls where everything suddenly feels more urgent. A small hole in the chest can quickly become a big problem, and recognizing that sucking chest wound means moving with a sense of urgency. That's where chest seals come in. Simple in concept, but critical in practice. The goal is straightforward. Cover the wound, help prevent additional air from being pulled into the chest cavity, and reduce the risk of life-threatening complications like tension pneumothorax. Sam Medical designs their chest seals with the realities of the field in mind. Packaging that opens quickly, materials that adhere even in less than ideal conditions, and venting systems intended to allow air to escape while limiting what gets in. It's the same problem-solving approach that made Sam Medical the name in trauma care. From tourniquets and splints to pelvic slings and bleeding control tools, because when seconds matter and equipment needs to perform the first time, reliability isn't optional. You can explore Sam Medical's full line of trauma care products at sammedical.com.
They are awesome.
They're great people. I got to have a training session with Bob Waddell to go through our tools of the trade this week.
Nice.
Yeah. He kind of walked me through how to use a Sam chest seal, which we have here,
which is our sponsored tool of the trade.
Our sponsored tool of the trade tonight is the Sam chest seal. Although I will say it's the tool of the trade tonight is chest seals, occlusive dressings.
Yes.
But sponsored by Sam Medical.
And we'll get into all that in the tools of the trade.
We sure will, which is all the way at the end of the podcast. So you can skip right through everything, get to Max's, segment.
No one wants to do that. They accidentally hit my segment on the way to Jonathan's. That's what I'm convinced.
They do come. They do stick around. That's why we put them last. It's because we know people will stick around.
We have to.
Yeah,
because no one knows how to fast forward a video. I mean, come on.
Well, most of the people are listening.
Even better.
Yeah, it's hard to fast forward.
It's harder to fast forward
when you're listening.
You guys have faces for radio as do I.
Oh yeah.
So
what are you talking about? I've got a face for male. Like I don't know. But yeah, we're having fun. We got stuff to talk about tonight.
We do.
But yeah, so Where should we should start off?
Where we always do. Medical term of the week.
Oh, because if you say we're going to start off where we always do, we're going to have to start actually talking about stuff in like 40 minutes after we talk about like Teenage Mutant Ninja Turtles.
I mean, we could go on a tangent if you'd like to.
Well, okay, so quick tangent. For anybody out there who likes movies, I saw a really great one a couple days ago, this week. I went and saw Project Hail Mary.
It looks good.
It is good.
Did you see it?
I did.
Yeah. Did you read the book?
I did.
Me too.
I hate to be that guy, but I think for having the source material, they did a really good job with the movie. But there were some things that I was really excited about in the book that just didn't come over to the film side. Kind of bummed me out. But overall, I think Ryan Gosling did a pretty good job.
I think he did too. I solidly put this movie on par with a movie adaptation with The Martian, which is the other book from the same author. So Andy Weir wrote The Martian. He wrote Project Hail Mary. That's why I read the book, because I was like, oh man, The Martian's so good. And I'll put it. I would put it at like a solid 8.8. Like,
nice.
Could it be better? Possibly, but then the movie would be like 4 hours long.
Yeah,
and it's already like 2.5. But
yeah,
it's a great movie. Highly recommend it. I highly recommend the book because it's a lot of fun. Like if you like science stuff and like biology and kind of going through like the scientific method, like it was that the book really does a lot of that stuff.
I will have to check out both, apparently.
Yeah, it's good. All right, so there's your pop culture reference for the week. We, Project Hail Mary. It's really good. All right, so I've totally lost my train of thought of doing this podcast.
Starting with medical term of the week.
Yeah, medical term of the week. I guess I have to do this one.
It's your section.
It's my segment, I guess. And it's the thing that we do to set the tone and kind of give a key concept that we're going to be talking about in the rest of the episode. So for this week, the medical term is paradoxical motion. So yeah, it explains itself, and we're done.
That's it. That's all we need.
It's a paradox.
Right, exactly.
It's confusing. So paradoxical motion occurs when a portion of the chest wall moves in the opposite direction from what is expected during breathing. So what does that mean? Okay, so if we're going to break it down, like we usually do, when you breathe in, you take a big breath in, your chest wall goes out. It expands. Because really what's happening on the inside of your chest is as you breathe in, your diaphragm pushes down, it creates negative pressure, your chest wall gets bigger, and it pulls it creates negative pressure on the inside, pulls air into your lungs.
Right.
When you exhale, your chest gets smaller, and that creates less negative pressure or positive pressure in your chest, and then you exhale. Now, the paradoxical motion is as you breathe in and your chest wall goes outward, if you have what's called a flail segment in your chest, in your rib cage, and we'll talk about a flail segment in a second, it's a section of the chest wall, which instead of coming out when you breathe in, it will move in.
Right.
Because that negative pressure that's been created on the inside of the chest is now pulling that section in. And when you breathe out, that little section might come out because you have positive pressure in your chest. So what's causing that? Why is that happening? Well, the pressure changes is what creates the motion. But the reason why that one section is going in and out is what's, commonly referred to as a flail segment of the chest. And a flail segment is multiple breaks along more than one rib. Right. So that there's basically like a riblet, like a McRib, of your chest.
That's a great way to picture it. That's a great way to picture it.
Those McRib, what I'm talking about, right? Like it's got the round shape and it's got several ribs in it.
I jumped to The Simpsons because there's that one episode where he's searching out that sandwich.
Yeah.
And it's that little riblet.
Yeah, I'm just gonna call
like
this. I'm just gonna call this the McRib syndrome from now on.
I like it. I think you should. I think you
McRib
should
is
try
back,
and
baby.
trademark it.
It's back, baby. So you have a section of the rib where there's the bone's broken on several, on two sides, and you have more than one bone, and all of a sudden that flap, if you will, that section of meat, no longer is structured by the bone,
Right.
but it's still connected to all the surrounding meat. So when you breathe in, it's loose and it gets sucked in. And when you breathe out, it's still loose and it gets pushed out. So you get the paradoxical motion, right? It's doing the opposite of what you think it should be doing.
And when you see a video example of it, if you decide to look it up, it is very odd looking.
Yeah.
Like if it's happening, you're going to know it.
And it can be different sizes too, because you could have large flail segments. You could have large McRibs and you could have small McRibs. Normally the McRib only comes in one size, which is that oblong bun shape.
Yes, exactly.
I kind of want a McRib now.
Oh, Jesus.
But the that's essentially what's happening, right? We have that section. It's now moving independently from the rest of the chest, and it's reacting to the pressure inside. Why is it important to look out for? Well, obviously, chest trauma, trauma with the ribs in multiple places is bad on its own.
That's generally a sign that something bad has happened.
Yep. Usually some sort of blunt trauma hitting the chest, breaking it in multiple spots is like a large object hitting it. That then has implications because it could be a sign of serious chest trauma, not just the flail segment, but to other things as well. Often the flail segment is associated with pulmonary contusions. So that's a bruise on the lung itself, which reduces the ability for the lung to do what it does, right? Like that's not good. You don't want bruises on your lungs.
It's not.
Really the immediate effect, the one that we're obviously always looking out for, is it can lead to ineffective ventilation.
Right.
So it could cause a breathing problem, which is our third step. So XABC. It's not exsanguination. It's not airway, but it's breathing.
It is breathing.
So that's a big thing that we look out for in the breathing world or in the primary assessment. So we want to make sure that they're getting enough ventilation, and it can be extremely painful.
I would imagine it's really got to hurt. I've had a broken rib. It really hurts.
And while that flail segment may not be directly affecting the lungs, the pain from that injury can be causing them to not breathe effectively.
Right.
They'll do the shallow breaths. They're not going to expel all the air that they need to expel. They're not going to bring in enough because it hurts a lot.
Right.
And oh, sorry. Go ahead, John.
You will see your vital signs affected by that shallow breathing. And the other aspect is you've got an unsecured section of, rib structure and tissue that's moving in there. So what additional trauma is that causing?
Right.
Yeah, because if bones are broken and they're moving about, we know that that's a problem.
You could puncture a lung. You could damage your heart.
You're certainly going to get additional soft tissue trauma from all the motion of that's happening around those bones. So really the story here is it leads to hypoxia in a few different ways. Obviously, that can be seen on vital signs, and it can lead to respiratory distress.
Right,
and that's the one that's like the big red flag for us, is making sure that we're looking for that. And really that's the thing. So when you're looking for it, you're looking for respiratory distress, the abnormal breathing, like shallow breathing. Somebody can't get a full breath in. That chest movement. You really should be looking for this more closely in things that can have a mechanism of injury that can lead to this type of thing, like we do with most trauma, right? Like in a violent car crash, we're going to look for the things that we know that usually come from violent car crashes. This can be one of them. The body hitting objects like the steering wheel, or even like the seatbelt itself, other things flying around inside the car. that can lead to a flail chest.
Right.
I had a call one time where basically the way that the road was set up, a guy was riding a bicycle. He was crossing the intersection. Well, the way the road was set up, the person driving could not really see. There was a blind spot in that turn, and the patient ended up getting run over by both the front and the rear tire.
Oof.
And and he was hurting pretty significantly. So did not see paradoxical movement, but he definitely had some rib fractures and then the shortness of breath associated with that, the shallow breathing. Yeah.
That's just bad all the way around.
Yeah. And then from an assessment side, getting your hands on it, and obviously you'll be able to feel, like if air is affecting that thing moving up and down, you'll probably be able to feel it too in palpation. Mm-hmm. And you're feeling for either the motion itself or maybe even possible extra crepitus from around it, and other injuries that could be in that area. So that's, the assessment side of it. And then treatment. We'll talk about treatment of chest wounds later in this episode. However, I'm gonna maybe step on the punchline here a bit, and there's not much we can do.
Right.
It's one of those things where it's like we look out for it, we identify it, and we make the patient comfortable. We put them in a position of comfort. We give them O2 to see if we can help with their breathing. But aside from that, it's kind of getting them to more definitive care. Or even getting our ALS assist buddies over to maybe do some of the cool med stuff that they can do.
Some pain management.
Well, and we'll talk more about it later, but there are a couple things that it just depends on protocols. So as you're listening, keep that in mind. I'm gonna talk about some treatment options for that, but they may not be in the protocols that you are using in your area. So just keep that in mind. But we'll get into it. There's a couple things that evidence-based medicine has shown to be a positive thing for us, and that's a little hint as to what it might be. So, but we'll talk about it later.
Cool. All right, so that's basically our medical term of the week: paradoxical movement.
Yep. But to understand what we're going to be talking about, we should really go over the anatomy and physiology of the chest. That way people understand what our discussion topic is.
But that's the boring nerd stuff.
It is the boring nerd stuff.
Anatomy and physiology. Well, who wants to take? Jonathan, you want to take the A&P section?
Sure. So our chest cavity has got all sorts of essential organs that require oxygenation, and they aid in circulation. And so we've got some major structures that we're going to talk about, like the lungs, right? We've already been kind of touching on that with paradoxical movement, paradoxical motion. We've got the heart. Hey, kind of important that we are able to pump oxygenated blood around the body. You've got your trachea, leads down into the lungs, and then you've got the bronchi inside of the lungs, and then of course you've got major blood vessels that run throughout the thoracic cavity, your aorta, your inferior and superior vena cava. Lots of things that can cause issues if they are injured during some sort of traumatic incident.
I didn't hear a single one that you said that wouldn't be a life-threatening problem.
Not a one.
Right.
Like there's a lot.
Right. Here's a big one too. You've got the diaphragm, and it separates the chest from the abdomen, and it plays a major role in breathing, right? On that positive, negative pressure aspect of the chest cavity. You've got some, as I mentioned, some major blood vessels, the aorta, the superior and inferior vena cava, and any injury to those, that's bad news.
Yeah. The whole idea of damage to the aorta, just can't see it, you can't touch it, you can't grab it, you can't stop it.
Yeah, and like the bleeding aspect too, especially in the chest area, abdomen too. It's like there's so much extra space.
Yeah.
Like that sometimes doesn't even exist, like where you think something would go into it, and then things moving into it then causes problems for other stuff. So like the lungs, the lungs are just space.
Yeah.
Like essentially that's their job, is to be space for air.
Mm-hmm.
Well, that's plenty of room for things to then fill up into, like blood and other air. Like, and that's what we'll talk about in like the pneumo and the hemothorax stuff coming up. But like all of those things getting compressed by bleeding or other stuff entering that area is bad.
I mean, it's like you would think, okay, blood and air is good. But yeah, well, blood and air has to be in specific locations for it to be good. Otherwise, it's bad.
Yeah.
So, and there's just, there's so much plumbing that goes on in that area that, any damage to it and you've got major issues.
I will say though. Oh, sorry. Go ahead.
No, yeah. Like the good thing is we have protective structures in our body that kind of keep everything in place, and if there is some sort of minor injury, hopefully protect those major things. We've already kind of touched on some of that, but you've got your ribs, right? It's truly a cage, a roll cage for your internal organs, as well as providing structure. You got the sternum, where the ribs attach, and then on the backside, you've got your spinal cord, and then at the top of your torso, you've got your scapulas, right? And then all of that is supported by muscle tissue, the pectoralis, right? So
unlike the neck, there is a lot of structure there and protection to try and keep the major things running as they should. And the idea of a flail chest, like the ribs have literally done what they're supposed to do.
Mm-hmm.
They're like a crash section, a crumple section on your car. They're designed to take the brunt, to do the braking so that the soft, gushy things inside don't.
You're not wrong. Like we think of that as the trauma, right? The rib fracture is the bad thing. Well, I mean, yeah, like that rib fracture probably stopped a severe internal like injury to an organ, because the inside's all filled with these squishy bits.
Yeah.
That's a technical term, by the way, the squishy bits,
Squishy
we're going to trademark it.
They teach that in advanced medical school.
That and the
like
McRib.
That's the squishies.
Yeah. The McRib and the squishies.
The McRib, yeah, that's also that's like year 7.
Yeah.
I'm just picking up all these really advanced medical.
That's for flight medics, right?
Yes,
just flight medics,
funny.
right?
Mm-hmm.
Yeah. Let's talk about how, and we've talked a lot about respiratory because it's really, really important. But let's talk about like the mechanism of breathing, and then later we're going to talk about how certain injuries can disrupt that.
Oh yeah, it's a big story.
So like you said, Mike, breathing depends on pressure changes inside of the chest cavity. And during inhalation, we've got our diaphragm that contracts and flattens out, and then you've got the intercostal muscles that expand the chest wall, right? That inhale, that exhale. During that inhalation, the chest cavity's volume increases and negative pressure draws air into the lungs. And then during exhalation, the diaphragm relaxes, the chest wall returns to its normal position, and the air is pushed out. And when we talk about trauma, what we're talking about is a disruption in that process, specifically, anything that might be blunt force or crushing. That can definitely have an effect on those on that process.
Yeah,
and like the process that's just supposed to happen automatically. Like you're not supposed to think about it. You're not supposed to have to work for it. It's just supposed to happen. So you wind up messing with that, whether it's through trauma directly to the chest or anything else, and you've got major issues on your hand.
Mm-hmm. Yeah, the chest stuff is. There's like the two biggest things that are in the perfusion story, like the heart and lungs, surrounded by all this, meat cage around it. Like there's so much that could go wrong.
Yes.
Meat cage is also,
it's a technical term.
That's year 9.
Listen guys, this is how my brain makes it work. I don't always express the michisms in there. Of like, oh, it's the meat cage with the McRib section.
We're getting quite a bit of expression.
Oh yeah,
tonight.
yeah.
It's fantastic.
Max, why don't you tell us a little bit about the anatomy and physiology of the abdomen? Though?
So-
because
that's only the chest is only part of the equation. We're talking about abdominal trauma as well.
So the abdominal area has a lot of parts to it, and it's responsible for many things like digestion, filtration of blood, waste elimination, hormone regulation, like just a few of the important things that maybe not be critical at the moment, but if they get interrupted or messed with, it's going to affect downstream quite a bit.
yeah, and there's all different little things like organs that deal with all those stuff.
Yeah. And these organs extend from the diaphragm to the pelvis, and mechanism of injury that predict which organs may be injured. So depending on what's happened, might be telling you what's going on. Like one of the things that we learned in class was labs. The idea that they identified the major organs in certain areas of the abdomen that could be, injured, and things that you should identify quickly.
Mm-hmm.
And so many organs, we have hollow and solid organs. Some of the solid organs are the liver. It's only important for filtering out your blood and all sorts of other things.
It's big though.
It is big. It's not, they identify it as this one section. And then when you see an actual layout, it's like, well, yeah, but it's over there and it's over there, and same thing with things like the colon. Like the colon seems to just go everywhere. So like, yes, there's a major organ in that area. The major portion of it is, but it's not just there.
Yeah, the fact that they overlap is a pain in the butt. Like it would be a lot easier if they could just make space and like a plate, like those plates that have like the ridges in them so that your food doesn't touch.
Yeah, exactly. I want it to stay in this area. And then you have the spleen. Any damage to that is going to be a major bleed because it's basically a filter for it's a sac of blood. So, I mean, it's going to be a major bleed. The pancreas, which is only, important for things like regulation of sugars and things like that. And then you've got your kidneys, which are responsible for filtering everything else.
Yeah, all the liquid stuff.
Yeah, all the liquid stuff. They all contain large amounts of blood, and any injury to them can cause severe bleeding.
And when did we talk about it? I think it was like
Abdominal.
Yeah, when we first started getting into abdominal emergencies, right? Like the idea between the hollow and the solid organs.
Yeah.
Like those things, they don't squish.
No.
As well as the hollow ones.
No,
do, right?
they
Those
rupture.
are the solid ones.
Yeah, and again, like they're going to be major bleeders. And then you got some of the hollow organs that also are in the same area. The stomach. I mean, that's not really important.
Well, I mean, I had most of mine removed, so it's not that important.
So, I mean, just take it out of there. You'd be fine. The intestines, which again, just snake throughout the entire area. And then you have the bladder. So these are the different types of organs you're going to find in the abdomen.
Mm-hmm.
And then with the hollow organs, they contain substances that may leak if ruptured, which can cause infection and inflammation.
Yeah,
and sepsis and things like that.
They have gross stuff in them.
Like they're moving things that you don't want spread out throughout your abdominal area to other areas where they can be dealt with.
Like, some of those hollow organs carry poop.
They do.
Yeah.
And that I don't think that's very sanitary when it enters the rest of your bloodstream.
No. There was a movie that they were obsessed in the movie about being shot in the abdomen, and one of the characters in the movie gets shot, and they do this graphic representation of the bullet going through and just the bile leaking out. So,
yeah, cool. Well, so okay, we know the parts.
Yeah.
Well, what about when things go wrong? I guess we should probably talk about the problems, the pathophysiology. The conditions which stop the things from working correctly.
Well, don't you just like cross your fingers and hope for the best?
Yeah. Well, that's treatment.
Yeah.
Right now we're talking about problems.
Got it.
So, Jonathan started with the breathing story, right? Okay, there's things in there. We have negative pressure. The lungs open up. We have air that draws in. Well, there's a bunch of stuff that can cause that to have a problem, right? You can have like the flail chest is a good example of like an unstable chest wall, something that all of a sudden that ability to hold the pressure in, if it can't hold up against pressure pulling in on it, then you can't create negative pressure.
Right.
And so the lungs don't open up. You can have stuff, we talked about it before, stuff entering that chest cavity, then causing the lungs to not be able to expand, like a hemothorax or a pneumothorax, or even impaled objects, like things getting into the chest cavity or collapsing the chest cavity, making it unable to for those lungs to expand outward,
like crush injuries and things like that.
Mm-hmm. So all of these things are very much bad. Like the stopping of the lungs doing the thing that they need to do is going to cause the problems of inadequate oxygenation, the respiratory distress, if they can even breathe at all. And eventually the Mac Daddy, the one that everyone gets to eventually in life, is respiratory failure.
Yes.
Because like that's what happens if we can't get them to definitive care, if those things are affecting the breathing story, right? There's only so long that we can last, pushing up against all these other things that are trying to like collapse our lungs.
Yeah.
So that's a big one. Disruption in the breathing, hemorrhaging and shock, which is terrifying.
It's terrifying
because when we're talking about hemorrhaging and shock inside of the chest and abdominal cavity, it's one of those things where we truly can't do anything about it. Like, we know it's happening. We might even see like blood coming out of like orifices or new holes. And it's not like we don't have the ability or the scope really to get in there and stop bleeding.
Nope. All we can do is get them to who can as fast as possible.
I will say maybe this is a good time to advocate for devices such as the AAJTS, like an abdominal aortic junctional tourniquet. Maybe not for all those types of injuries, but something that is low enough where that can be effective, can be something really important. But for the most part, things above that umbilicus, the belly button area, there's not a lot that you can do on the especially on the BLS side for any type of internal bleeding. And we're going to talk about treatment in a minute, but like that's what's happening. It's just bleeding on the inside, and there's only so much you can do. You just try to keep as much in as you can.
And the idea, first you have to identify what the hell's happening.
Yeah. And it's coming from the things that you mentioned, the solid organs, the major blood vessels, that aorta or the vena cava. They contain large amounts of blood. And, for instance, like you can have an internal bleed in your chest cavity, and that can contain up to 3 liters of blood.
That's a lot of blood.
I think, what do you have? 8?
5 or 6 of them?
5 or 6?
Jonathan?
Of liters of blood?
Yeah.
So average healthy adult male has about 5 liters of blood.
5 liters.
But then when we start to look at other populations outside of the average healthy adult male, we start getting less blood volume depending on size and age and potentially pre-existing medical conditions. So the idea that your chest can hold
more than half.
Yeah, well, 60% of your blood not in your blood vessels in the chest cavity. That's
a bad day.
Yeah.
And and we're going to talk more about specifics, but I've had patients where more or less we have found them later. They've had some sort of traumatic injury. In the instance I'll talk about later, it was a car crash. And what we think happened was an aortic dissection, right? There was enough force to shear that aorta. And this particular patient showed no other than the fact that she was dead, but she showed no outward signs of hemorrhage.
Right. Yeah.
And but it was very, very easy to determine that's probably what happened to her.
Yeah.
Right.
Yeah, in those big traumas, that's the one that kind of worries me. They all worry me, but like the thing that you can't see whatsoever.
Yeah.
The people who have dissected aortas, where it's like it's just their time. Like there's nothing you can really do about it. Like
maybe you can get them to definitive care fast enough that they can intervene. Maybe
for a dissected aorta, I don't think that's possible.
Yeah.
like just based off of what's happening inside the body, unless you have, possibly something that can put pressure on the aorta.
Yeah.
I don't think if that's any higher than say the belly button, like there's really nothing you can do in the field for dissected aorta.
Oh, no. There's definitely no intervention. All you can do is try and get them to higher levels of care.
And I mean, even if they were laid on a surgical table, I mean, the likelihood is very high that they will not make it off that surgical table.
A dissected
alive.
aorta on a surgical table is deadly. Like it's you'd have to cross clamp, and by the time you even cross clamp an aorta, you may have lost enough blood that even with somebody ready to go in and clamp that thing off, the moment it happens, there's a chance you don't make it. So, but yeah, so like the hemorrhaging and shock is a big part of that story, especially when it comes to trauma. Which of course leads, so any of that hemorrhaging, losing that blood leads to the shock, the hypovolemic shock. And, that will present in the way that we've seen it, we've talked about it a bunch of times before, all those shock-like symptoms, the cool, clammy skin, the tachycardia, possibly lower blood pressure too. Hopefully, you catch stuff before the blood pressure starts lowering, you get into decompensated shock. But those are all the things that we're looking for in those shock symptoms. And that's all from the bleeding. And then, we might even get things that are disruption in like the other organs that are in there. However, I will say, I in my head, and correct me if you guys feel differently, it seems like this is a bit less of an acute issue, like because you might have a disruption in like some of the digestive system that happens from the trauma, or you might have a disruption in the renal system, or those things get problems too, and those may cause some acute issues, but they're not as acute as like the respiratory system, circulatory system, those types of things.
This is what's going to kill them later, eventually, right? And but it is a problem. And then one of the big issues is a lack of perfusion causes tissue death, which ultimately can cause organ failure, and we may experience that organ failure due to that lack of perfusion, right, to these organs. But I mean, you may get somebody there alive, and then a few days later or a week later, they die because of massive organ failure.
Yeah, right. Yeah, because the body can only recover from so much, like and necrotic tissue can't come back to life.
No.
So the lack of perfusion, once shock starts setting in and they're not getting the nutrients that it needs, you're going to have tissue start dying, and it's going to happen everywhere. So some of that stuff is going to affect things faster than others. Like if that's happening with the lungs, the heart, the things that cause that the kind of central perfusion system, if you will, that's gonna cause things to happen more quickly, but it'll happen to the whole body. And then the last kind of part of this pathophysiology story is again something that's not acute right now, but we try to do whatever we can to head this off at the pass because of how bad it can be later in terms of infection. So this is why we try to do any type of aseptic techniques that we can in the field, even though, well, really at the end of the day, the infection is something that's, is probably going to come into play much later down the line.
Oh, for sure. I mean, I think no matter what you do, it's going to be introduced, which is why they're so quick to give antibiotics.
Yeah. I mean, that's
because any break in the skin, especially if it's a trauma where it's really invasive, like it's there.
Yeah.
And hopefully they can control it.
And not even just a break in the skin per se, right? We've already touched on it. We've got lots of organs that contain bacteria inside of them. And as a closed system, that's fine. That's what they're meant to do. But when we start getting, perforations in bowel sections or, in other parts of the body, internally, we're still releasing that bacteria in places it's not supposed to be. So yeah, I mean it can be a major issue, but on the short term, that's the thing that's going to kill them later.
Yeah. Right. Yeah. So I mean, things we have to worry about for sure, especially if somebody's been in a trauma before and we're seeing them down the line and we're like, hey, you're not looking so hot. You seems like you have an infection there. We're looking for those types of signs because we may not see the initial trauma. We may go and respond to them afterwards too.
I mean, it's just the example of, an elderly lady that falls. Like she may, decide that she's okay, or she may be dealing with where the pain is. And we may see her 3 or 4 days later, and then we're dealing with sepsis and every other,
perhaps,
thing
yeah.
down the line. So.
Like I have a buddy who almost died because of diverticulitis. Now it wasn't technically a trauma, but that was something that like a perforation in his colon led to severe infection and then sepsis and all the stuff that happens from that infection story. And it's just to say that, while it's part of trauma, it could be something that's down the line. And just because it's down the line doesn't mean that we may not see it.
Right.
In our practice, we may have to recognize it some other time too.
When we talk about the infection aspect of it, this is where getting a good history comes into play. And especially if, like you're saying, Mike, because that's a great point. I think a lot of the times in EMS, we think about the point of injury and then we're responding to that. But we may respond to this, this issue later. Right. Oh, I was in a car wreck 3 days ago. And now we're starting to see some of these later signs. Right. And even then I still think a lot of the times about the hemorrhagic shock aspect, right? Maybe we have a tiny bleed and over a matter of days, that's when we start to really develop issues.
Yeah. It's a slow leak. It's still a leak.
It is.
You might even wind up seeing the same patient. You might respond to their initial call for a fall, and then you're the one that comes back to the house 3 days later for the next fall because they lost consciousness because of the hemorrhagic shock.
Yep.
Yeah, ask me how I know. That's happened on numerous occasions where you answer one call or another crew answers a call at a house and then, they called the rescue squad 3 days ago and, mom fell and she didn't want to go and now we're back out here.
Yep.
What have you.
Yeah.
Yeah. We were on a call and I think we should responded at 1 a.m. to, lift assist or whatever and tried to talk the lady into coming to the hospital with us. And she called again at 3:30 and they had to get her there in a hurry because she was critical.
It's always fun rolling with people that are regulars at the service that you're at because they give you all the insights on like you get all the information you really need to know when like an address pops up and like from my perspective, I roll like usually I'm in the back of the ambulance because I'm the third, right? And you just hear a groan come from the front of it, like, this guy
or this neighborhood or this,
Oh, that like usually it's like the shady like old folks home. I forget what it's called in our. Well, actually, I'm just not going to say what it's called in my area. But like whenever a call comes up there, they're like,
here we go.
Wait, which apartment is it? Oh, her. And it's like I know part of me doesn't want to subscribe to it because I know what we really should be doing is focusing on the care.
Yeah,
but
you don't want to be jaded.
It's part of the aspect of the job is like you're going to deal with like interesting and difficult personalities sometimes.
Sure.
But.
Do you guys want to? Okay, so I always try and put a positive spin on things for the podcast, but gallows humor is a part of being in fire rescue.
Yep.
And so talking about that sketchy nursing home. Everybody's probably been to one. We have one where the designation is like the name of the nursing home and then health and rehab as the additional aspects of the name. Well, we have turned it into the name of the nursing home, and instead of health and rehab, it's death and dying. And
D&D.
We're going over to the death and dying.
Yeah.
And it's pretty rough, right? And a lot of these staff members at these places do the best they can, but they're so underfunded and under-supported.
Yeah.
So, but yeah, there's a little gallows humor for you as far as a real-world perspective.
And it's the reality because the reality is that as EMS, we deal with systems.
Yeah.
And sometimes those systems are very imperfect. like because they're made by people and
Yep.
people are imperfect. So
exactly.
but at the end of the day, what we're really here to do is try and make that person's day a bit better. Like we're there to provide care, and like that grounds me. But it's still it's still hard to sometimes go, oh yeah, I know what I'm about to face because I just heard all I needed to hear from the front seat from them going, oh no, not again.
All you can do is give them a smile and try and be as sweet or as nice as you can.
Yeah. So now that we know a little bit about the pathophysiology, the things that can go wrong, systematically, if you will, on the inside, why don't we talk about some of the specific things that can happen, like the mechanisms of injury, if you will, that can cause the injuries. You want to take it, Jonathan?
Sure. Yeah. So, in general, when we talk about mechanism of injury, we can have penetrating trauma. We can have blunt force trauma. We see a lot of blunt force trauma when we talk about mechanisms of injury, because ultimately, like a fall, a motor vehicle crash, there is always the opportunity of penetrating trauma, right? From an object. But a lot of the trauma is going to be blunt force, right? So in the instance of MVCs, motor vehicle crashes, right? Or falls, right? Somebody falls off a ladder, assault and batteries, right? Even things like sports, right? Like heck, in football, the whole goal is to knock the other guy down, right?
Yeah.
Boxing, the whole goal is to knock the other guy down. So that's kind of an induced trauma, right? That's the whole point. But yeah, so all sorts of things. Falls and motor vehicle crashes are going to be the vast majority of things, but it could be anything really, as far as blunt force, being put on the body. Where does that come into chest trauma? Well, we've talked about rib fractures, contusions to the lungs, internal bleeding, and then, as I mentioned a second ago, penetrating trauma. We can get into that as well, right? So we got gunshot wounds, right? That's something that we're familiar with talking about in other aspects of our lives, and stab wounds, and then impalements, right? Here's the one that we may see a lot of in EMS is impalements of objects, right? Somebody falls onto something.
Like a rebar sticking out of the ground, or like an old road sign that's broken off,
Yep. A stick that's come through during a motor vehicle crash, or even a part of the motor vehicle that's impaled into the patient, right? These can initiate things like a lung collapse, of course, bleeding. And then we've talked about infection. We have to be concerned about that, because any object that's not supposed to be in your body that is impaled into you is going to carry bacteria.
Unless it came directly out of an autoclave. I mean, that's a possibility too.
It's true.
Yeah. And if we have other aspects of some of these mechanisms of injury, right? Crush and compression injuries, shearing injuries, right? We have a shearing force. And those, depending on the level of force put on them, could still also be blunt force trauma as well. Right. We've got a paper mill in the area that I grew up in and work in, and they deal with all sorts of machinery, and they also have these large, paper rolls that they move around, and talk to some guys about. Yeah, they are heavy. Talk to some guys that have had paper rolls crush them. Right? Like that's a very real possibility in that area. And you can get things like, you can have a crush injury that causes issues with being able to breathe, and cause contusions of the lung if there's some sort of force behind it. You can have dissection or lacerations of major blood vessels, like your aorta or your vena cava, like we've talked about. All manner of things mechanism wise, but we have to be able to assess that mechanism, and then kind of in understanding what that mechanism is, we can kind of start to go towards what's the likely pathophysiology of these injuries and what is our treatment path for that.
Right.
Yeah.
You know, we've talked a lot about rib fractures, right? Paradoxical motion, right? With a flail chest segment. But we don't have to be as extreme as going immediately to that flail segment. The gentleman I mentioned earlier that got ran over with the bicycle, our concern was a flail segment. But as we assessed him and exposed his chest wall or his torso.
You exposed his chest wall.
Exposed his chest
No,
wall?
as he exposed his torso.
Those shears are amazing.
That sounds invasive.
No, I'm joking.
He did have tire marks over top of him.
Yeah.
Right, as a bruise, a contusion, but his chest wall was mostly intact. We didn't have a flail
That's
segment.
not what you want to hear.
I'm sure. Well, the thing that I think did occur was he did have potentially a fracture to his sternum, and then potentially a separation of cartilage. Right. So that was a potential issue. But in general, with these different things, you're going to have pain at the injury site. You're going to have, and this is the big one, you're going to have pain upon inhalation and exhalation.
Yeah.
I've been there.
Yep. Same.
That's going to be a big sign that, hey, maybe something's not quite right. Maybe they have a fracture somewhere. It's going to be tender to the touch. And again, I said you saw tire marks on this guy. That's bruising. That's a contusion to the exterior. And then shallow breathing. That's going to be a big one. These people are going to be in so much discomfort that they're probably not going to want to take breaths that are going to help oxygenate them like they need to be.
Yeah.
Yep.
So, and again, complications of that are going to be hypoventilation, right? Not breathing adequate to support life.
Yep.
So, and then like later down the road, we could talk about pneumonia as a thing, or, a punctured lung, right? It's very possible that a rib section does puncture a lung.
Which then could lead to like the or pneumothorax.
Yep.
Well,
Right.
a pneumothorax or collapsed lung if a rib section punctures a lung.
Yeah.
But then also a hemothorax, and you can have, it's a chicken or the egg kind of thing. You can
Yeah.
have both occurring at the same time.
Hemo-pneumo.
Ooh.
Yeah.
And the big thing in that is they need to be in a definitive care environment or with a higher level of care. I think some flight programs are allowing chest tubes to be put in. With a finger thoracostomy, yeah. And but in general, we just need to recognize it and get them to definitive care with due regard.
Right.
But priorities are going to be to maintain adequate breathing, oxygen administration, and then continuing to monitor them for respiratory distress.
I assume too is maybe trying to put them in a position of comfort. Like if you got somebody with there might be some angles that they're probably more comfortable in than others.
If the flail chest is on the right side, don't lay them on the right side.
But just broken ribs in general, like they're so like they
suck.
if you're in a particular angle, breathing in a particular way, like you might find some relief too, like just as in a way of treating and caring for patients, like helping them get into a position that doesn't hurt as much might help too.
Yeah, position of comfort is important, and in a lot of instances, as we've talked about musculoskeletal trauma in some past episodes, we talked about pillow splints and padding areas and things like that. That's an important thing. If we can pad an area that's injured to keep them from bouncing around and give them a little bit of support, we definitely want to do that.
As a matter of fact, sorry, I didn't mean to cut you off, Jonathan, but like good. I know I've gotten relief from like holding a pillow, like from having a broken rib, especially if you're coughing, like if you have a cough at the same time as a broken rib, like
Mm-hmm.
holding on to that pillow and not necessarily splinting yourself, but giving them something to kind of brace that might actually provide some relief as well. Not necessarily part of like a prescribed part of the EMT scope that we went through in school, but just anecdotally things that I've seen, that help with broken ribs.
I had a friend who had a pretty nasty accident, and he broke 3 or 4 of his ribs, and the next day he got the flu.
Ooh.
So he was coughing and vomiting, and it got to the point where they had to put him on pain management because he couldn't take it.
Yeah.
Like, it was bad. It was really, 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 really bad.
And so as we've touched on that flail chest segment, right? That paradoxical motion, and having that segment of unstable chest wall just kind of moving about. Again, respiratory distress is going to be a big thing, which leads to hypoxia, which leads to shock, and all the things. The biggest things that we can do for these people is oxygenation and ventilatory support. And then, of course, rapid transport. And I want to take a second I want to touch on this because I mentioned it earlier.
You did.
We may not, this may not be in everybody's protocol. So I want you to, if you're listening, proceed with caution and take in my word for it. But in a lot of places, positive pressure ventilation is going to be the go-to thing. We used to do all sorts of crazy prescribed things for flail segments that we don't do anymore. But the big thing is positive pressure ventilation that has shown to create favorable outcomes. And even CPAP, non-invasive ventilation with CPAP or BiPAP. That being said, it needs to be in your scope of practice and it needs to be in your protocols before you would want to initiate that. But some places are letting EMTs do that.
And I would also say that if you're looking at chest trauma, and we haven't gotten into pneumothoraxes yet, but if there is a suspicion of a pneumothorax, that's a contraindication of CPAP. So because you could add extra air into the system by doing that. So it's just like a watch out, because like if it's like just a assistance in breathing could help, but if it turns in, like, you have to monitor them for make sure they're not getting a pneumothorax at the same time. That's one of those things where it's like, I can help, or I have to be cautious.
And it doesn't necessarily even need to be CPAP. It could still be like you're using a bag valve mask.
Yeah, exactly. Any positive pressure. Yeah.
So those are some things that we can potentially do if our protocol allows us to do it. That's kind of the way we're trending, but that's kind of the interesting thing about EMS. Protocols are going to vary where you're at, and best practices are going to vary, but based on those protocols. So I don't want to speak for everybody, but that's just something to think about. And if your protocol allows it, then that's an option for you.
Yes. Follow the protocols of your service.
Yeah.
No matter what.
So it sounds like, okay, so we got the some chest injuries.
Yep.
It sounds like those were the blunt trauma chest injuries. But what is like, we had blunt, we have penetrating, and then the third one was compressing, right?
Yes.
Like, what are the penetrating ones?
So with penetrating chest injuries, really you have to watch out for open wounds. Like, do you have something that's physically going into the body? And what is that wound looking like? We talked about it before in other episodes. Like, for the most part with the penetrating trauma, like, you're not pulling the thing out. Like, that's the key thing.
Impalements,
we don't pull it out.
Yeah.
But like, what's going on? Do they have difficulty breathing? Can you see issues with their ventilation? Are they able to breathe? Do you see signs of bleeding? Is this that has something that has to be addressed? And then also signs of shock, whether it's hypovolemic or hypoxic shock. Like, what's going on with the person?
Yeah, like, definitely there's things we're looking for, and like with penetrating injuries, the definition is there's now an opening.
Yes.
Right? Like, somewhere in that chest wall or chest cavity, there's an opening to it.
Whether it's from an object you can see or something that's passed through the chest.
And there are degrees of penetrating trauma into the chest, right? Where we may have a small puncture into the chest cavity, or it may be a large, penetrating trauma into the chest, which leads us to a sucking chest wound.
Right.
Yeah. So,
well, from my perspective, all chest wounds suck.
Right. But the main thing is with care priorities, like we have to maintain their airway, support their breathing. That's where occlusive dressings do come in with penetrating trauma, is the ability to stop it off, to not allow air to be passing into the chest cavity, and then rapid transport.
Yeah. And to your point, a very big part of this story of the penetrating chest wounds, when there's an opening to that, either because this is the first time we're kind of touching on what do we do if there's openings,
right?
Openings that shouldn't be there,
right?
There's really one answer.
Yeah,
I mean, like there's some nuances, like we'll talk about eviscerations in a little bit, like for things in the abdominal cavity, but for the most part, the answer is put a dressing on there that can't breathe, that doesn't allow air to pass through. Because
otherwise, when you get that positive pressure, you can be drawing air into the chest cavity.
Yeah. So occlusive dressings are pretty much the go-to for anything in that chest cavity, or that any type of holes that shouldn't be there, because all of a sudden we're trying to keep anything that shouldn't be in there out. Yeah. And anything that should be in there stays in.
And if you start getting to something like tension and pneumothorax, the ability to allow air out, and some of the chest heels have valves on them that are one way that allow the air to escape.
Yeah. So like the injuries that we could see from those penetrating, those penetrating injuries, or the injuries within because there's the injuries on the outside.
Yeah, and then there's injuries inside.
And then there's the injuries that can happen on the inside. And the one that we've been dancing around all night, that probably the three of us are most familiar with, is the pneumothorax.
Correct.
Or the thing that it evolves into, like a Pokemon. It gets its rare candy and becomes no, is that not how it works?
No, it might be how it works.
That's exactly how it works.
I'm growing it sounds like a Pokemon name, doesn't it?
It does. It really does.
I'm growing my pneumothorax into a tension pneumothorax.
Right.
Because the tension physiology happens as that thing gets worse.
Right.
So a pneumothorax is a hole in the chest cavity, where it's letting air in, and it's creating pressure on the inside of the chest that shouldn't be there, and not allowing the lungs to expand.
Right. So restricting the ability for the lung to expand.
It's just collapsing. Right. It's the collapsed lung, right?
Yeah.
Which could also happen spontaneously like in weird situations. I had it happen to a friend of mine. Apparently, tall, slender men have a chance of getting spontaneous pneumothoraxes, not from trauma, just because they're either sick, coughing, or one day their lung decides to go and deflate. I don't know. It's weird.
So and let's talk about it, because we're talking about penetrating trauma to the chest, and we talked about blunt trauma to the chest. So in talking about that pneumothorax that may evolve into a tension pneumothorax, we have to think, is this an open or closed? Now, we're talking about penetrating trauma right this second, but even with that blunt force trauma, we could have a closed pneumothorax.
Oh, sure. Yeah.
Occur.
Right.
And so that's something to keep in mind, is, just because you don't have a penetration into the chest doesn't mean you're not going to develop a pneumothorax.
Yeah, because these are things. Yeah. Sorry, go ahead.
Yeah. In fact, most of them are going to be closed pneumothorax.
Yeah. Because what we're talking about right now is injuries that happen within the chest, regardless of it being a penetrating chest wound or a blunt chest wound.
Right. So if air is escaping the lung into the chest cavity, it's going to cause the same thing.
Correct. Yeah, like a puncture in the lung itself can come out of the lung, and anytime that air is coming out of the lung is bad.
Yeah.
So you get the pneumothorax, right? The lungs collapses. If that gets so bad that not only does it collapse the lung, but that pressure inside the chest starts pushing on other anatomy, like the major blood vessels or the heart, that starts creating what's what's known as a tension pneumothorax. So the air gets in, it can't escape. It compresses the heart and the vena cava, and it reduces cardiac output. So not only can the person not breathe, but all of a sudden it stops the heart from being able to pump the blood. So it's working double time to kill them.
It's not good.
Yeah, very not good. And it causes severe shock, right? And this is something like we're familiar with the idea of a chest decompression needle. This is not in the BLS scope anywhere. But ILS, I think, in some places, and definitely in the ALS scope, something that you should be aware of, because I think that it's one of those things that's like there's such a high likelihood of trauma developing into pneumothoraxes that you should be able to look for those tension physiologies and be able to call that out immediately.
And what would it present as? Like, what are some of the key presenting features of it?
Well, the trouble breathing is probably the first thing that'll happen.
Tachycardia.
Yeah.
That'll definitely go in there. And then a late sign, one that our book actually didn't mention, or I didn't see it, but I know it from other previous trainings, is the tracheal deviation, where there's so much pressure happening on the inside, it's pushing up on the heart, and the heart's pushing up, and everything's getting in there, and it's literally pushing the trachea over to the side, and you'll see that kind of deviation in the neck.
Yeah. The other aspect is hypotension, right? Because of that reduced cardiac output.
So it would be hypotension, not hypertension.
Yeah, hypotension, yes.
Okay,
Low blood pressure.
because the blood can't push hard enough. So yeah, you have that's the pneumothorax.
Especially with motor vehicle accidents. I mean, like you're talking about all these different things that can shear and push, and just the thing that's supposed to help you, the seatbelt, supposed to save you, could cause chest and abdominal trauma.
It could.
A twofer.
It's not a reason to not wear your seatbelt.
It's not,
folks. I know people that are like, oh, I don't wear my seatbelt because it can cause a tension pneumothorax. I'm like, you know what else it prevents from happening? Instant death.
Yeah, the steering wheel will do the same thing when you fly into it.
I don't understand people who don't wear seatbelts.
No, I don't either.
But,
no. Wear your seatbelts, people.
Wear your seatbelts.
And here's the thing, provider tip. If you're in the back of the ambulance and you have the ability to put a seatbelt or a harness on,
do it.
Wear that stuff, guys.
Yeah.
Like, really, wear it.
Yeah.
So if the pneumothorax is an air type Pokemon, well then there's a water type.
There is
as well.
a red water type.
Just it's like I could go into Pokemon metaphors way too easily, I think.
Wouldn't it be cool if, because remember there were certain Pokemons you'd use a particular like stone to evolve.
Oh yeah.
Them. What if you used a
like
bloodstone?
Yeah.
What if you used a bloodstone to evolve it into a hemothorax?
Yeah.
Medical Pokemon cards.
Yeah, it'd be a Hemovorian.
Yeah.
Like, for an Eevee or something like that. Like a Vaporeon was like the I think that was the air type.
It was the air type, yes.
Yeah. So the water type
was a squid.
Vaporeon was the water type.
Oh, yeah. Vaporeon was water type.
Yeah.
Whatever. So the hemo, there's a hemothorax.
Right.
So if pneumothorax, pneumo being air, hemothorax means heme, blood. So blood entering the chest cavity. And essentially you're seeing the same thing. It's just something else coming into that chest cavity, filling space that the lungs would prefer to occupy.
Yeah, the lungs are like, I want to be over here doing what I'm supposed to do, but there's this thing that's keeps pressing and it keeps getting worse and worse and worse and worse.
Yeah. And like, as far as, I mean, from what they kind of talked about with us, the physiology, like the outward signs seem to be pretty much the same. Reduced ability to breathe. Like, I think what you'd probably,
rigid abdominal, wasn't it one of them?
It could be.
The abdomen can get rigid.
Well, but the abdomen isn't what a hemothorax is bleeding into.
It's true.
That could happen from a bleed into the abdominal cavity. but I think one of the big ones is if there is like holes and wounds, you might see like spurting and more liquid and blood coming out of that as well. And especially because, you know, what are the chances that you get one or the other? It's never a clean thing, right?
No,
like,
the bullet's going to go in. It's going to go 15 different directions. It's going to hit the lung. It's going to hit bleeders, and you're going to have both happening at the same time.
Because then you get the what would be the Pokemon equivalent of two Pokemon? Like now you have Pokemon breeding, where you have the hemopneumo,
Exactly.
The hemopneumothorax, where all of a sudden you have like blood and air entering the cavity, all mixing together, turning into a frothy mess of nastiness.
Yes.
I'm sure. Then, you know, coming out of holes and stuff. So, but that's the reality is like when you have that much trauma coming into the chest, if you have air entering that place, you're probably gonna have bleeding getting in there. So, like all of that, just it's really the same story. Stuff getting into this cavity, you want to stop that stuff from getting in if you can, and really, you know. As the more of that stuff that gets in there, the more it's going to reduce the ability for the lungs and the heart to do what they're supposed to do.
Exactly.
Can you get a tension hemothorax, Jonathan? Do you know off the top of your head?
Yeah, you can have blood and air in the chest cavity.
Yeah, I figured as much.
Yeah. I mean, eventually, well, essentially the issue is the same. You still have chest pressure built in the pleural space, and that's not allowing the lungs to expand and contract. And the ultimate thing is the result is going to be the same, right? If it's not dealt with. So again, recognizing that tension physiology, recognizing those signs, and those symptoms it's going to be super important because they need to be sent to definitive care.
Yeah. Right. So, okay, we've got a few more left in this kind of category of things of the injuries inside the chest. This next one is kind of not necessarily just inside because traumatic asphyxia is not a story of just something happening inside the chest, because usually it's happening from things compressing the body so that you can't breathe.
But it's the same story. Like you're reducing the space, so it's causing the same.
Yeah, it's an injury inside the body, but it's pretty much from an exterior source that's collapsing the chest wall, right? So it's the same thing. Lungs can't expand. You can't breathe. You know, what does that lead to? Hypoxia, cyanosis. Like the signs of not being able to breathe correctly.
Like the example of Jonathan talking about the motorcycle running over somebody and having those like, you know, that crushing the chest to the point where you have that going on.
Yeah.
Oh, it was a pickup truck, like a 250 that ran over a guy on a bicycle.
Jesus.
Yeah. It was not good. And it's purely a thing of, yes, the pedestrian had the right of way, but he couldn't see him because of the way the road is laid out.
Gotcha.
So we have the traumatic asphyxia. We also have the cardiac tamponade.
Yes.
Which I don't care how many times people tell me it is not a thing. It still sounds like it's a dip that you can get at a Greek restaurant.
It is 100% a question that I got wrong on the testing.
Yeah. I'm like, excuse me, can I have the baba ganoush and the cardiac tamponade, please?
Yeah.
No, this is one of those things that it's a similar story to the pneumothorax, because it's stuff entering a space that it shouldn't be in, reducing the output of the thing that usually lives in that space.
Right.
So in this story, we're talking about the heart and the pericardium, and stuff like fluid getting into that space in between the heart and pericardium, then collapsing the heart, basically putting pressure on the heart so that it can't pump. Yeah, it accumulates there, and it leads to reduced cardiac output, and that's from the injury to the chest, like, you know, blood getting in there, maybe leaking out of the heart itself. It could have a couple of different reasons why it's happening. It doesn't really matter though, because if that happens long enough, the heart stops.
Yeah,
and that's not good.
And then the scary one.
Oh,
the
The one we've chatted about this one before in the abdominal
injury
section.
dissection.
Yeah, so aortic injuries,
Yep.
dissection.
Those two words together are just terrifying. Like you shouldn't have dissection and aorta in the same statement. That's a bad thing.
Yeah. Essentially, you're going to see this one in like severe motor vehicle crashes, like where the body is like thrown in one direction or possibly change direction like very quickly, where you have like that kind of shearing motion going on within the body. And it's massive internal hemorrhaging.
Yeah.
There's the chances of anybody surviving it are so astronomically small because essentially you're emptying out the entire blood volume of the body.
You're dumping your entire blood volume into that space.
Into the chest.
The call I was talking about earlier with that aortic dissection, it was a motor vehicle crash, and interestingly enough, so where this woman wrecked her vehicle was at a T intersection, and so she essentially, and the weird thing was it was early in the morning. Or she had wrecked her vehicle at night because rigor had set in by the time we were on scene. But we were dispatched right at shift change, and I had just driven through there. Well, along this T intersection, there was a row of trees, and there was actually a traffic sign, like a big, large traffic sign. And so she must have fallen asleep or something like that. And she just plowed right through this traffic sign and then went over the embankment and was in a field. But the thing was, like I said, I rode through there just before this call was dispatched, and you could not see her because of the trees.
Yeah.
You could not see the vehicle. And so once we got down in the woods, we found her, and what looked like had happened was she had this motor vehicle crash, had enough life in her to take her seatbelt off, and she had like crawled across to the passenger seat, like across the console and kind of reaching into the passenger seat. And then ultimately that's where she died. But yeah, that's exactly what happened to her is a aortic dissection. And to be able to get the vehicle where she got it, she had to have been moving pretty fast. And it was the sudden stop that got her.
Yeah.
So it's a real thing.
It wasn't the fall that killed her.
No,
it was the sudden stop at the end.
Yes.
But okay, so to wrap things up in the chest category, if you will. So we're talking about those injuries inside the chest. What can we do? Well, it's a pretty simple story.
Yeah.
Because it's not a lot. I think if it's a penetrative injury and you're before you even suspect it developing into a pneumothorax, hemothorax, or a tension physiology, you should be putting occlusive dressings on those to prevent them from happening, right? A vented chest seal on the top side of a body, a occlusive dressing on the back side of a body, or whatever the bottom side is. Like if there's an entrance and an exit wound, essentially you don't want to put vents on the bottom sides of bodies because all that stuff that's on the inside, particularly if it's liquid, will come out and possibly plug the vent. So you'd probably want to just put a regular occlusive dressing on the bottom sides and then have air be able to escape through the top sides of patients with a vent.
Yes.
Right.
So putting on occlusive dressings, vented chest seals, so it allows pressure out but not pressure to go in.
Right.
Right.
That's if it's penetrating. If it's anything else though, it's really the same story. If it's a chest injury, you're looking for those things that are indicators of shortness of breath, inability to breathe adequately. And what's our answer for helping patients that can't breathe adequately?
We give them O2.
O2. We help them. Yeah. We help them with their perfusion. We help them with their oxygenation,
and maybe positive airflow, depending,
and maybe positive pressure ventilation if we need to.
Yep.
And really, it's identifying the things, figuring out what the problem might be, and then getting them to definitive care.
Yep.
That's the big one. Oxygen to help them breathe if you can. Intercept with ALS. because they may be able to help out with a few more things that you can do, and rapid transport.
Yeah.
That's really the story.
Yep. And especially with ALS, the ability for them to give them pain meds so that, the ventilation for them isn't as bad.
Yeah. And of course, I know we say this all the time, but the things that we can always help with if they go poorly is like the primary assessment stuff. So we're making sure that we're like, if they develop an airway problem, that we're there to help keep that airway open.
And like what you just said, like the idea of continually to reassess your patient, especially if they've been in a trauma.
Yeah. All right. So we've gone through the chest.
We have.
Like an alien symbiote in its larval stage. We've gone through the chest.
Yes.
Let's
that's terrifying, isn't it? Like the xenomorphs popping
is.
out of a chest.
Yes.
Let's circle back for like just a second, because this just occurred to me, right? We mentioned penetrating trauma with impalement. Let's talk just for a second about the treatment for that. Obviously, all the things that we have talked about with providing, providing oxygen and that sort of thing, all of that still applies, but stabilizing that object.
Yeah.
You mean don't wiggle it around to see if it'll just fall out on its own?
No, don't you just push it through? Isn't that what you do? Isn't that how that works?
So we don't remove the object. And then if it's an object that is, not pinned to something, right, that's going to require some other assistance from maybe your fire department to get that object cut down. But there are people who are trained to do that particular type of,
they have all the
type
toys.
of thing, right? But stabilizing that object, let's say it's a stick and it's impaled, and we just need it's not all the way through. We need to stabilize it, and so we can do a couple different things. We can use gauze. The best thing to do would be to have something that is an object to stabilize it. There's actually Sam's sister company, Rescue Essentials. They have a product that allows it's not a SAM splint, but it is a padded moldable form that allows you to stabilize that object and make sure that it does not move around, causing any additional trauma. So I just wanted to really quickly mention that, because we kind of glanced over it.
Yeah,
for sure.
It's good too, and what's nice is it's reiterating things that we've also talked about before. So there's a lot of themes in EMS that make things easy to remember. Penetration or impalements. The story is the same for impalements no matter where you go. Stabilize it and make sure it doesn't cause additional damage. Right.
Exactly.
Yep. Don't remove it.
Don't pull it out.
Nope.
Or push it through.
No, neither one. It shouldn't move in either direction.
Either one is the answer.
But yeah, no, that's a good point, Jonathan. Thank you. But yeah, so that gets us through the chest, and now we get a little bit lower. And I think what's nice is the story of the abdominal section. It's not necessarily as complicated as the chest area, because the chest area has things that affect more directly the primary assessment, like the things that go bad right now. But there's still a bunch that happens in the abdomen, right? Who wants to take abdominal injuries?
Eviscerations.
You want to take eviscerations?
Sure. Evisceration.
I knew you would want to take eviscerations. What is an evisceration?
So an evisceration is when you have a hole in the abdominal wall and you have organs that are protruding from it.
Any organ?
Any organ that protrudes from the abdominal wall wound is an evisceration. So you could have the colon, you could have any of that stuff. If it's trying to come out, that is an evisceration.
You want to see Max go on a tangent? Max, didn't they do that as like a form of medieval torture?
They did. They did. If you've ever seen Braveheart, there was a wonderful example of it.
Yeah. No.
You probably shouldn't use the word wonderful with evisceration.
No, do not.
But it's such it's a wound that is a distracting wound in a way, because all you're going to do is first, don't push the organs back inside.
Well,
So,
yeah, the first thing you do is nothing. You don't
do
it.
not push the things inside that came out.
Yeah.
You're going to cover them with a moist, sterile dressing, and you're going to cover them with an occlusive dressing.
Yeah, like if you can.
And main thing is prevent heat loss, because when your organs are on the exterior, you can easily go into hypothermia because it's going to lower your body temperature.
Yeah, you want the occlusive dress. Like basically, you want to keep them wet, and you want to put things on them that make them stay wet.
Exactly.
Moistness.
But it's like
the essence of wetness.
But in a way, that's why I think of it kind of as a distracting injury, even though it's very visual. There's not a whole lot you're doing to affect change to it, except for try to keep it as it is now. And obviously, you're covering it for infection reasons, because that is a huge area for infection.
Yeah, I would say, yeah. And the eviscerations are just, they're
dramatic,
gruesome.
Yeah.
Yeah. But essentially, I think you're right. It is kind of a distraction injury because it's so overwhelmingly visually impairing to see somebody's organs spilling out of them. But it's like, if you just do what you need to do and get them to care, they can take care of that at the hospital.
Yeah. They'll put all that stuff back where it belongs, and they'll close the wound, and there you go.
Another I want to kick gunshot wounds, which could happen in the abdomen, over to our resident tactical instructor.
He is a resident tactical instructor, isn't he?
For medical purposes, he's the guy I go to for these types of things. So I would love to see if you got any insight on gunshot wounds, Jonathan.
No pressure.
Okay, so I think that when we think of gunshot wounds, it is penetrating trauma, right? I also want to add into this discussion of gunshot wounds. I want to add in knife wounds as well.
No, they're totally different. They're not the same thing.
So I want to add those in there as well, because while velocity is an issue, we do have some similar points to talk about with them. There's a super high potential, especially in the abdomen, of a bullet or a knife striking a vital organ and causing internal hemorrhage. And the big thing about it is, depending on caliber, depending on all sorts of things, depending on angle, we may have damage all the way through the abdominal cavity, because bullets don't. It's not like in the movies. It's the example that I always use when talking about bullet trajectories. We like to think of it as like, oh, it's like a lightsaber, It's Star Wars. It's straight through. It's cut completely off, right? That's not how it works, because angles, and then you get deflection from the bullet potentially striking something, and we don't know the extent of the damage that's done internally to these folks when they have these injuries, these mechanisms. We don't know the extent of what organs are involved. The big thing is internal bleeding, and there's pretty much nothing that we can do about that directly. These people need to be rapidly transported to definitive care, appropriate definitive care. Kind of a further point about knife injuries. We get tissue compression with knives being used. So just because somebody has a 3-inch knife doesn't mean that our wound channel is only going to be 3 inches in depth, right? Because as somebody is applying force to that knife and it's going into the tissue, that tissue is compressing. So we may have injuries deeper into the body than we think.
Right.
So what you're saying is it's not the size of your knife. It's how you use it.
Right. Crocodile Dundee comes to mind. That's not a knife. This is a knife.
You call that a knife?
Yeah. So
I mean, just a kitchen knife. Just a kitchen knife.
Yeah. Those they're all terrible. Yeah. I mean, I don't want anything, but I would probably, if I had to choose getting shot over being stabbed with a knife.
Yeah, a guy with a knife that knows how to use it is terrifying.
So I've got a book that, and you guys may have seen this book, but basically it's a book that accounts or recounts all of these Old West gunfights.
Mm-hmm.
And in this book, they look up all the different documentation, right? Like all the different reports. So it's a historical book, right? They really want to focus on the data of what actually happened in this incident. And some of these instances where people were shot in the abdomen, they don't die immediately. They would die days and weeks later of infection. Sepsis. Right, of organ failure, yeah. And so that's one of the big issues with gunshot wounds to the abdomen, right? We've touched on it a bunch. We've got so many things in our abdominal cavity that are supposed to have bacteria in them, but when that bacteria gets out of that kind of closed system, it's not good for the outcome for the patient.
Yeah.
So
cool. Yeah, so a lot to think about when it comes to those like gunshot wounds. The one that always kind of just fascinates me because I've hunted a few times and I've seen like bullet trauma or gunshot wounds on actual like living tissue, and the path that it travels is so non-predictable sometimes. You can have a deer that's shot in the shoulder and it comes out like by its back knee. Like because it can travel along, weird routes, along muscle groups after it loses a lot of velocity. So it's just to say that like, bullets do weird stuff sometimes in the body. You may not have an exit wound and an entrance wound, or it may make a weird jog and turn one way and start, somebody may be shot in the belly button and it may turn up and go into the chest through the diaphragm. You never know.
Yeah, it hits those liquids. And
the other thing is, when we talk about bullets, high caliber rifle rounds often will tumble, right? So it's not just a straight pass through. It's like once they hit that, we're mostly made of water as human beings or fluid filled, right? Once it hits that water in our bodies, it starts to tumble in there, causing all sorts of additional damage because of that tumbling.
Yeah. Mm-hmm. So what you're saying is humans are water type.
Yes.
I would say that we're probably more water type than anything.
Yeah.
Yes.
Okay. So to wrap this thing up.
Yes.
We've talked about, the chest stuff. We've talked about things that can happen in the abdomen. A couple of particular types of injuries that can happen in the abdomen, but really the treatment and assessment for abdomen stuff stays relatively the same.
It really does.
And it really, there's a couple of things to consider in the, two categories, closed and open. Mm-hmm. So just like everything else, like the closed abdominal injury is something that you can't see a hole that has happened on the outside versus an open abdominal injury like an evisceration or even a penetrating injury where you can see a hole that's gone in. For all of them, either open or closed, we're doing this. There's some core things that we're doing the same. Monitoring for primary assessment.
Yeah.
Like we do that for everything. Everything that we do.
No matter what.
We monitor for the primary assessment. We make sure that, somebody has a patent airway, they're breathing and they're circulating. We're looking for signs of shock, right? Like that's understood everything that we do, but we can't say it enough because it's our primary role. We're treating for hypothermia.
Yep.
To help stave off some of those shock symptoms. We're utilizing positions of comfort because they're going to be in pain. And if there is a position that they are more comfortable in that isn't compromising their ability to breathe or do anything else or receive other patient care, we're going to put them in the more comfortable position, right? We're not going to give them anything to eat or drink because anything that could be affecting the abdominal area could cause issues with the renal system or the digestive system, and we don't want to give them anything that's going through those, because that could just cause problems in the very short term time where they're going to be going to a hospital and then getting work done, right? We're not going to, and the thing that we're also looking out for, and this comes back to that kind of primary assessment, like being aware of something that could cause an issue with that is vomiting.
Yeah.
If they have abdominal pain, anytime there's abdominal pain, anytime there's pain in general, there's a chance that somebody could be so overwhelmed by it that they just get sick.
Right.
And there's a lot of other things that could be happening too. And internal bleeding could lead to bleeding through the esophagus, from the mouth. You could cause problems in other places. So we need to be aware of those things affecting the airway. So we should have suction ready, ready to go to make sure that those things aren't getting in the way if they happen to pop up. And then, of course, rapid transport. Getting them to definitive care. That's the big thing. Yep. That's what we can do best. It's what we do. I got to start driving the ambulance, by the way.
Did you?
I did. Yeah. That was fun. Those things are really heavy.
Yeah. And you can feel it when you drive the vehicle.
Yeah. I was trying to be the most gentle around corners that I possibly could, because the only person in the back was our paramedic, who was like, okay, go get some driving practice in. And I'm like, sure, no problem. And like, I'm trying to go like driving Miss Daisy around the corners. And we got back to the firehouse, and she was like, all right there, Mario Andretti, can you not, try and give me the rough ride around the back of the ambulance? I'm like, well, I need to recalibrate in my head. And yes. I'm not a crazy driver, but anyway, ADD break.
The best thing that you could do here's a hint. The best thing that you could do is go sit on the stretcher and have somebody drive you around. If they'd be willing to do that, strap yourself in on the stretcher and just see what it's like.
Yeah.
To have somebody drive you around. And then that gives you a good idea of what you're doing to other people driving.
I know. I understand, because I ride in the back all the time, and I'm like, okay, and I know how to drive gently. Apparently just don't understand how to do it well enough yet in that type of vehicle. So
it takes time.
That's why they don't let you do it when you first start driving an ambulance, like on an emergency call with patients in the back. You got to do it a few times without that. So sorry.
You're fine.
We did the things like that we do for all abdominal traumas.
Yeah.
And then if there's an open wound, an open abdominal injury, like you had mentioned for evisceration, we're not putting anything back in.
We are not.
We don't put anything in the body.
No.
We're going to cover exposed organs with sterile moistened dressings with saline. We're going to cover those dressings with an occlusive dressing, if possible, something that's large enough to kind of keep that moisture in.
Yep.
We're going to secure the dressing without applying any excessive force, right? We don't want to put pressure on those things. We want to keep them wet, and we want to keep them warm.
Yeah.
We're going to, stabilize any impaled objects, like Jonathan mentioned before. Yep. And we're gonna treat for shock.
Yeah.
The same thing we do with everything else. But really, that's the thing. The thing to watch out for the open wounds or open injuries, things that we can't necessarily work against directly right now, but things that are like, hey, if we take whatever precautions we can, we're trying to reduce the risk of infection, additional organ damage, and additional internal bleeding.
You're gonna give them a better outcome.
Yeah.
Or hopefully give them a better outcome.
All right. We've made it through chest and abdominal trauma.
We have indeed.
We only have one more trauma episode left after this.
Multi-system or whatever.
This plus that plus this other one plus this plus,
You mean because it's not always just one system that's affected?
It's the smorgasbord of trauma.
It'd be great if the body could just figure out what it wants to have injured at a time. That way we can just, structure it that way. It'd be great.
Yeah. I agree. It would be great. Just like the body that has separators for all the organs.
Yeah, exactly.
We'd have
make
just
it
be
clear.
able to compartmentalize.
Exactly.
Okay. So we're through the meat and potatoes of tonight's episode.
Yes.
And we've finally gotten to our tool of the trade, which we've talked about a time or two in terms of an occlusive dressing. Now, occlusive dressings can fall into a couple of different categories. We have some of the older, like, like things that, well, really anything can be an occlusive dressing if you try hard enough.
As long as it is not allowing air to go into the body.
Yeah.
You are occluding it.
You can literally make an occlusive dressing from saran wrap. And
can.
Some people have done that.
Duct tape and plastic. Duct tape and the wrappers for medical items.
Just the duct tape.
Yeah, just the duct tape.
Is an occlusive dressing.
Or you can have
if it's small enough.
Or you can have a dedicated product that is made to do this.
Right. And so they make things called chest seals.
They do indeed.
Which, doesn't have to be used on the chest per se.
It does not.
But, a chest seal is something that's an integral part of most BLS kits. I've seen them in a few of the bags that I've been in. It's also a widely used tool in the tactical training world,
it is
in the tactical medicine world. So tonight, our tool of trade is
the chest seal.
The chest seal,
which is sponsored
by Sam Medical, who happens to make a really good chest seal.
A very intelligent chest seal.
Yeah, they have some features on there. We won't go too deep into all of it because we can, like, we know we talk very highly on Sam, and there's reason for it. But the biggest one on this particular chest seal is usually the chest seals have vents on them that can be that are very passive. Like they're either like there's like a channel that runs in like a tube, or it's like a flappy, like whoopee cushion type tube in some things.
A flutter valve.
A flutter valve. Thank you. Yeah. Obviously, my technical terms were not satisfying to Jonathan.
And sometimes it's literally just a channel where the hydrogel isn't present.
It's a channel, like a pathway through two pieces of occlusive dressing, so that air, like air can pass one way, but not it collapses and doesn't come back the other way.
Exactly.
Sam makes a chest seal that has a protected valve on it.
Yes, so it is known as the through flow valve. And it prevents the collapse of the venting because it has a rigid cap on it.
Right. Which is, I didn't see that before or anything else. I'm like, okay, that's pretty awesome, because usually when you're putting on chest seals, there's other things around them. Like if you have, if you need a chest seal that's on like the back of somebody, or like a vent on one side on their back, if you roll them, it's not going to close.
It's going to collapse it very well.
If you have somebody that gets shot, people who wear body armor, things that are heavy pieces of clothing, that sometimes can't be taken off by the time you have to put a chest seal on. If that thing falls back on that chest seal, normal chest seals will sometimes get closed because of that, and it won't allow them to vent. A protected vent doesn't collapse when something touches the top of it.
It's a very, very intelligent design. Some of the features of that in particular is it's flushable with saline or on like a channel seal. Other things, like every chest seal, most chest seals are using something called hydrogel. It's very sticky, so it'll stick on almost any surface, whether it's blood soaked, cold, hot. It also is better for downstream providers because it doesn't leave a lot of stuff behind. It's easy for them to clean it off.
Yeah. There's a lot of benefits to the Sam chest seal. If you want to check those out, they have all the information on them. But essentially it's what we think of as a really fantastic example of a chest seal.
Exactly.
How do we use those, Max? Like, what are they?
So chest seal basically has a transparent backing that the way you can see the wound, you can see what you're placing it on. It also has a sticky front. Most of them using a thing called hydrogel. Some are vented, some are non-vented. We talked about that. The vented type generally has a channel without that sticky gel, or they have what this has, which has a positive valve that's there. Some of the older tech, they would use Vaseline gauze.
Yeah, well, Vaseline gauze. Jonathan, when you started, was there Vaseline gauze on your ambulance?
There still are.
Yeah,
there still is. Yeah,
me too.
So, the whole idea is like that petroleum coated gauze is not going to allow air to pass through it, but there are better solutions to this problem.
As a matter of fact,
than that.
So when I was talking to Bob Waddell, who was giving me the lowdown on the Sam chest seal, and kind of, for us to kind of get up to speed with it, he told me this story, and I was laughing my ass off because he's like, yeah, well, you know, the thing how we used to use Vaseline gauze back in the day, everyone would have them. So we would take them and we would open them up and we would take the Vaseline gauze out of the wrapper and we would throw the Vaseline gauze away. And then we would take the wrapper and tape that on as an occlusive dressing.
Yeah.
100%.
Yeah.
That really speaks to the Vaseline gauze.
The wrapper of a Vaseline gauze is more effective as an occlusive dressing than the Vaseline gauze is.
I have a
Go ahead.
I have a non-standard use of the Vaseline gauze.
Oh, really?
If it's a very particularly hot and swampy summer, you can take care of some personal hygiene things with them, and hopefully feel better if you've got chafing.
Well, that's interesting. I'm definitely gonna keep that one in mind.
That's an alternative use of them. But yeah, so when I started out, Vaseline or petroleum covered gauze were really part of the thing. We had other chest seals with flutter valves and things like that.
Yeah.
But they present some issues when they're utilized. They don't like to stick to anything bloody or sweaty, or just in general wet, right? So there's a better way to do things, and I think we've got to a point technologically where we've got some really awesome products out there that address this. The other thing that we used to use is a roll of saran wrap.
Mm-hmm.
Yeah, man, I don't miss those days.
So we touched on what they're used for. They're used for open chest wounds, also used for penetrating trauma as well as neck trauma. That's another thing they can be used for.
We talked about that last week.
So areas where you can't pack the wound, that is basically where these are going to come into play. Applying the chest seal is pretty straightforward. You open the packaging. Most of these have some kind of a tear tab in them somewhere.
Hopefully they're easy to open.
Hopefully they're easy to open. Like this one in particular, you can see it has like pre-cut little tabs you can pull at. You're going to center the vent over the wound. Basically aim the center vent towards that hole that's in the body. You're going to apply on exhalation, which I had not heard before. So if possible, press the chest seal down firmly as the patient exhales. Yeah,
that was one of the tips from Bob, from Sam, in terms of, and this is universal for any of these chest seals, in that when you breathe out, that's when you have the least amount of pressure,
right?
That's trying to get in. So you can put it in there, and then it kind of assists in keeping the pressure out of the chest.
We don't want to trap that air,
right? And then once you have a place, just make sure you have the edges sealed.
Mm-hmm.
So that's basically as far as applying it goes. A little bit of history into them. We talked about petroleum gauze. That was used early on. The 3-sided method where medics were taught to tape gauze only on 3 sides, and that allowed you to have that flutter valve that we talked about.
Yeah, and it works. Like, if you're in a pinch and you need to improvise something, if you take a square piece of like foil or plastic packaging or whatever, you tape down 3 sides, that will work as a vented seal.
Yeah. But later research showed that these improvised dressings rarely worked as intended.
Mm-hmm.
So during the War on Terror, 1990s, there's a couple ones that came out. Jonathan mentioned the Asherman chest seal. It's one of the first widely adopted commercial vented seals. There's also something called the Bolin chest seal, developed by H&H, and this was used multiple one-way valves to allow air and blood to escape, even if the valve became clogged. And then the hydrogel revolution, where basically they created this product that would stick onto skin, whether it was hairy, bloody. In 2013, the TCC officially recommended vented chest seals over non-vented because studies showed that non-vented seals were significantly increased the risk of tension pneumothorax.
Mm-hmm.
So that idea allow air out. Also, a couple different things have changed. They now come generally in twin packs because generally if you have an entrance, you have an exit.
Generally.
And then civilian adoptions, lessons learned from the War on Terror, leading to the Stop to Believe movement and inclusion of chest seals in standard patrol and ambulance kits.
You know what I just realized that I can't believe we blew past and forgot to mention? That there's a really great example of the of what it looks like, or a representation of what happens inside the chest for a tension pneumothorax in the movie Three Kings.
Three Kings. I thought about it earlier.
Oh yeah. I was like, oh my God, I can't believe we forgot to talk about the movie with George Clooney, Ice Cube, and Mark Wahlberg in it.
We're horrible.
Yeah. We're gonna have to do this whole podcast over again and just talk about. No, I'm kidding. But yeah, so make sure, like, if you want to understand what's happening in the chest, because in that particular movie they use like, I believe they use a decompression needle, correct?
Yeah, they do, and then they use a one-way valve on it, and the issue in that is the valve has to be opened to release pressure. And in the movie, spoiler, Mark Wahlberg's character is captured and he's unable to release the pressure, and so he's starting down the path of a tension pneumothorax. Right,
and so it's to say that if you watch that movie, understand what's happening. He gets gradually increasing pressure. In modern chest seals, they have that pressure release valve in them. So if that chest seal was placed on, then it would help relieve some of that. Right. Well, in that particular instance, maybe it wouldn't fix his problem because he may have needed the decompression needle to release that pressure on the inside. But if there was a big gaping wound that was causing the tension pneumo in the first place, then as he's breathing out, the air could or the pressure could release through the chest valve or the chest seal itself.
I think the main lesson from all this is there's a bunch of different ways you can do it with plastic wrapping, duct tape, saran wrap, or you can have a dedicated piece of kit that does it is intended for that purpose.
Yeah, there's a reason why they're on ambulances. The reason why they put them in kits is because you don't want to have to take the time to improvise something if you have a really good option available.
Exactly.
Rapid application.
Mm-hmm.
So there you go, chest seals.
Awesome. Yeah, and thank you for putting that together, Max, and thank you, Sam Medical, for sponsoring this episode and our tools of the trade section. They just they make really great stuff. I know we've said it like a million times, so it feels like we're beating the dead horse, but like they're great people and they make great stuff. So Sam Medical, you should go check them out.
Yep, for sure.
Awesome. Okay, so we've gone through our tools of the trade, which leaves one last section.
The one everyone's been waiting for.
The one where Mike and Max make a fool out of themselves because they answer incorrect, easy questions.
I'm all for it. I'm right there.
Okay, so time for the student tips / student test prep of the week.
Oh, man.
I've got some questions for you guys.
Amazing. All right. I'm going to pull up the question so that I can read it when you ask it to us.
Yes.
Because it's hard. It's hard to do it just audibly. I
can't stand. I really. There's something lost in the whole thing when it's not. I really do prefer being able to read the questions for sure.
All right. So the first question. It's going to be, which of the following is responsible for carrying oxygen throughout the body?
Okay.
All right.
Answer 1, hemoglobin. Answer 2, lactic acid. Answer 3, platelets. Or answer 4, carbonic acid.
Okay. So I think we do this as we always do and try and rule out the ones that are incorrect. I think I've locked into my answer. My guess is you have too.
I'm 100% locked into an answer.
But let's go through the process. So hemoglobin to start with.
Mm-hmm.
Hemo means blood. So that would be the key for me is that hemo in the name in the word.
Mm-hmm.
Lactic acid. I don't think anything that is acidic is carrying any oxygen. So I would rule out lactic acid and the carbonic acid. And platelets is thrown in there. It's part of the blood. But if you know anything about it, it is not really intended for the purpose of carrying oxygen. So for me, I landed straight away on hemoglobin.
I just happen to know what I remember what hemoglobin is.
Yes,
so that's one of those ones where I'm like, I know what the answer is because that's a red blood cell.
Exactly.
I'm 100%. You're right. Like, and I like the context of like, oh, well, heme, there's something to do with the blood with that one. And if you don't know it off the top of your head that is what it is, then that's a good context clue.
Yep.
You are correct.
Nice.
Hemoglobin is the answer.
1 for 1.
1 for 1. Ooh.
All right. Are you guys ready for the next question?
It's a long one.
Ooh, yes, let's do it.
All right. Give me a second. I'm going to pull this up. All right. During transport, an adult patient with chest discomfort has vital signs taken every 5 minutes. The heart rate has increased from 88 to 104 beats per minute. Blood pressure has decreased from 128 over 84 to 102 over 68. And respirations have increased from 18 to 26 breaths per minute. What term best describes the process of comparing these repeated vital signs to identify changes in the patient's condition? Answer 1, triage. Answer 2, index of suspicion. Answer 3, reassessment. And answer 4, trending.
I'm 100% locked in, although I will recognize that there are 2 answers on here that are probably close to one another that could be tricky.
Yeah, agreed.
What about you, Max?
So it's definitely not triage.
It's definitely not triage.
Like triage is just immediately thrown out. Index of suspicion.
I'm going to be honest. This is one of those times where I'm like, I don't think I've ever heard that term before.
Neither have I.
But it might be a thing.
So as we talk about, just as a helpful hint, as we talk about mechanism of injury, index of suspicion is related to mechanism of injury.
Okay. It's a term that I probably did not catch going through school, like in terms of a way of thinking about something. So
it could be 2 different ones.
So here's my thing: reassessment and trending.
Mm-hmm.
Both of those are technically correct.
Exactly.
So this is one of those questions that might have one that's like, what's more correct?
Mm-hmm.
Because the process of rechecking vital signs every 5 minutes is reassessment.
Correct.
However, the process of comparing those vital signs is trending. So my answer would be trending.
Same.
You both are correct. And that's a great line of thinking, right? This is where reading the questions really, really comes into play. Because that process of rechecking vital signs is reassessment, right? But when we're comparing them as we go forward, we are trending them. We're looking for trends or changes in those vital signs.
Yeah.
So,
and if you glossed over that question and then saw the answers, you could easily land on reassessment.
Yeah. Like when I first read through the list of 4, I was like, reassessment done. Oh wait, no, it's asking for trending. But cool. All right, 2 for 2.
2 for 2.
Yeah, buddy. All right, we're gonna redeem ourselves.
This is where it just all goes to hell.
Yeah.
All right. So you are part of the first EMS unit to arrive at a mass casualty incident with limited resources using standard mass casualty triage principles. Which patient would be assigned the lowest priority for immediate care? An unresponsive 64-year-old patient in cardiac arrest with agonal respirations, a responsive 22-year-old patient with partial and full thickness burns to the entirety of both legs, an unresponsive 12-year-old patient with unequal breath sounds in respiratory distress, a responsive 32-year-old patient exhibiting signs of compensated shock.
Okay. So I think in this case, again, there's 2 that you can immediately rule out looking at, what the question is. The 2 that I think you would definitely land on as for me, like first ones to pay attention to is the unresponsive. Like the unresponsive thing for me checks off who you would go to first.
Okay.
Well, so think about it this way, Max. It's not who you go to first. You've gone to all of them, but it's who has the highest likelihood, or who is the one most deprioritized to put efforts into.
Right.
That's what it's asking, right, Jonathan?
Correct. Yeah.
Okay. So with that, I'll give you my rationale. So I'm going to go through this list and give what I would think is the tags for them in a triage tag situation. So an unresponsive 64-year-old patient in cardiac arrest with agonal respirations. That's a black tag.
Yep.
For a trauma situation, the cardiac arrest puts them as black tag.
Yep.
All you do is, try to give them a head tilt chin lift and hope that the pulse comes back, because you got other stuff you got to worry about right now, right?
Right.
Okay. A responsive 22-year-old patient with a partial and full thickness burns to the entirety of both legs. So he's responsive. There doesn't seem to be an immediate life threat. Right. So I would not put him into a red category.
Correct.
Either a yellow or a green. He's not walking,
He's
right?
not ambulatory, so it's a yellow.
Not related to the question. Well, related to the answer of triage, I would give that person a red tag.
Okay, so that would be a red tag. The thing throwing it off for me is because, like, depending on the situation, if there's nothing immediately, if he's not having trouble with breathing or burns are bad, but that's what in my head what I was looking for. But okay, if he's a red tag, an unresponsive 12-year-old patient with an unequal breath sounds in respiratory distress, that's a red tag because he's not black tag and he's in respiratory distress, which is the highest priority in terms of he needs immediate attention.
Yep.
And a responsive 32-year-old patient exhibiting signs of compensated shock. Well, he's responsive. He's in compensated shock. That's also a red tag. That's life-threatening conditions there. So basically you have a black tag and 3 red tags.
Yes.
Right? So which one do you deprioritize?
If I was going to deprioritize any of those 3, I would say the 32-year-old with the burns.
No. Of the 4, which do you deprioritize? Meaning which
black tag.
Which one do you not give any efforts to?
Black tag.
Yeah, that's the answer, is the black tag.
Yep. And that is correct.
And that was reading the question, because the initial hearing of it was like, okay, well, they're looking for the one that you would go to first. But the question is to ask you, which one are you pushing aside to go care for the others?
Right. Which patient would be assigned the lowest priority for immediate care?
Yep.
And the lowest priority for immediate care is a black tag, because you put literally no efforts into a black tag.
Yep.
100%. Yep. That is correct. Being able, and that's kind of the thing. All of these patients are red tags. So how do we eliminate that? Well, the one patient's a black tag, and you guys are spot on with that. So, hey, that's been our student tips, student test prep of the week. And you're 3 for 3 this week.
Hell yeah. 2 weeks in a row, 3 for 3.
Yeah, that means there's going to be the next 5 weeks. It's going to be just bingo after bingo after bingo.
There's going to be a week where it's going to ask me Jonathan's going to start throwing in the EMR questions again, just to trip us up.
That or they're going to get into hazmat, because hazmat is a whole soup sandwich.
Oh, hazmat's rough. Or anything where it's like ICS is like, man.
I am suddenly having to be an accountant and having to procedures.
Yeah.
And that's definitely not a strength.
My worst, the category that I had to spend most time on, because we spent the least amount of time on it in school, going through the nitty gritty of stuff, was OBGYN. Like birth stuff, where it's like, in this situation, if this is happening, there were terms where I was like, I don't even remember I don't remember hearing this.
No, 100%. There were some questions where I was like, okay, that term was never gone over.
Like placenta previa. I'm like, I don't remember what this is. And I had to go back and study, because that was definite, which is good about doing those test prep programs. They will tell you where you're deficient, and you can go study on stuff. But
Awesome.
This is great. Thank you, Jonathan, for guiding us through the process of preparing for our test that we have already passed. But we do it for all of you out there.
Yeah, it's for you. It's for you. Yeah, you right there. You.
He's pointing at the camera for those of you listening.
For those of you watching, you know I was talking about you.
So that brings us to the end of tonight's episode.
Yep.
Stay tuned next week for multi-system trauma.
Everything's going on. Everything's happening, and we're panicked.
Yeah, I mean, it's going to be a lot, although I think it's going to be a challenge for us to make sure that we're not diving too deep into any particular type of trauma, and we're keeping it in the context of things like working in conjunction with each other. It's going to be a challenge, I think.
I agree.
Just like multi-system trauma.
Exactly.
So, let us know how things are going for you. Where have you been struggling? What part of your education are you in? Are you close? Are you just starting? Hit us up. Shoot us an email at ridealongpodcasting@gmail.com. We'd love to hear from everybody.
Yep.
We love taking this journey with you guys. So thank you for taking the journey with us, and we'll see you next time on the Ride Along. This podcast is for educational and storytelling purposes only. It is not medical advice or official EMT training. Always follow your accredited instructors and local protocols.
Heartbeats racing in a